we have talked for ages and ages very much about subtypes in bladder cancer, but in the end, prostate cancer is a little bit the same. We have very many different types. So the most frequent type is the acinar prostate cancer, where we have two things. We have the different histological patterns, which come from this same cell line, let's say. And then we have the subtypes, which are morphologically distinct and have really prognostic significance. And in these subtypes from the acinar prostate cancer, we have 4 subtypes, which is the pin-like, which is not very aggressive, but are very aggressive. The signet ring cell-like, the sarcomatoid, and the pleomorphic type. Then we have the ductal adenocarcinoma, which is a subchapter part, which is an aggressive disease and has to be mentioned because we know very well that do not respond very well to hormonal therapies. Then we have the treatment-related neuroendocrine tumors, which are also in a known chapter. They're still in the adenocarcinoma chapter because these are tumors which under ADT therapy will have a neuroendocrine differentiation, and then we know these tumors become extremely aggressive, and it's very, very complicated to treat them. The pure neuroendocrine, of course, is another chapter, is really put together with all the neuroendocrine tumors. And then we have, last but not least, these adenoid cystic cancers, which are pretty aggressive, luckily very rare, but we do not know very well how to treat them. So in the end, of course, Gleason score is important, but the subtypes are very important. And there are some articles which have been published saying, well, it's a real difference whether you have a classical acinar prostate carcinoma or whether you have a neuroendocrine or whether you have a ductal adenocarcinoma and so on. So it's really important to read the whole report in a kind of concentrated manner.